But we're going to keep moving on and moving forward, and I'd like to introduce the second speaker, who's my friend and colleague, Dr. Kumar Basu, who is the Clinical Director of Sheffield Gastroenterology. So he has 30 consultants who moan at him every day, but he's going to talk to us about dysphagia. Thanks, Kumar.
Thank you, David. So, dysphagia, what do you need to know from the endoscopy? We do about 15,000 endoscopies in Sheffield every year, well, in a normal year. About 2,000 of those are open access. About 50% of our referrals come on a two-way wait pathway. So dysphagia is a very common indication for endoscopy. So I'm going to talk about some types of dysphagia for you, differential diagnoses, the role of endoscopy, some clinical tips for primary care, and those will be highlighted in red, and diagnoses you may not have thought about. So what is dysphagia? Well, dysphagia is basically a subjective awareness of difficulty in swallowing, and there are various different types, or three main types. One is oropharyngeal, and there's an oral stage of swallowing involving the tongue, mastication, creating a food bolus. Then there's a pharyngeal stage where the soft palate rises to cut off your nose, the epiglottis closes off the larynx so you don't aspirate, and the food bolus is passed into the esophagus. And then there's the esophageal stage of the food bolus being transited to the stomach. Now these can go wrong at any of those stages. Oropharyngeal is usually neuromuscular and is characterized by difficulty in initiating swallowing. Esophageal dysphagia can be mechanical, structural, or can be neuromuscular as well. And then, as always in gastroenterology, we have a functional element as well, where there's difficulty in swallowing, but you can't find anything wrong. Two things to distinguish from dysphagia, these are the symptoms. Adynophagia, which is painful swallow, the patient's clutching their chest after they swallow, and globus, where the patient's complaining of persistent lump in the throat and clutching the throat. Now, adynophagia is characterized in the history by a painful swallow, especially to hot, cold fluids. That coffee hurts on the way down. That's not very common in gastroesophageal reflux disease, even if you've got quite severe inflammation. And it's characterized usually by infections, candidiasis being the commonest one, and pill esophagitis, certain medications. So when someone comes with a history of adynophagia, make sure they're not actually describing food sticking, they're describing pain on swallowing. The risk factors you might want to explore are they on steroids, antibiotics, non-steroidals, are they immunosuppressed, are they taking drugs which we know can damage the gullet, and biphosphonates is a big one. Tetracycline you may be less familiar with, commonest cause of pill esophagitis in the USA audit. And looking at the oropharynx, there may be evidence of candida. You don't need an endoscopy. Course of fluconazole, endoscopy saved. If someone's immunocompromised, I probably would go for an endoscopy because there are unpleasant conditions that can affect the gullet in people who have those conditions. Globus. Now, globus has a characteristic history. It's a sensation of a lump in the throat. It has a constant presence, unlike mechanical dysphagia, and it's there with dry swallow as well. There is no true dysphagia. Patients can get food down. It just feels like there's a lump as it goes down. It's often due to some cricopharyngeal spasm or hypertrophy. It's related to anxiety as well. It is a distractible symptom, but beware of changes in the voice or iron deficiency anemia. That may need an ENT referral. It can be reflux related to something called laryngopharyngeal reflux, which I'm not going to really touch on, and very uncommonly can be related to this thing called an inlet patch, where you get a bit of gastric mucosa high up in the esophagus. That can be diagnosed endoscopically, but is rarely the cause of globus. And globus does not need an endoscopy in most instances. Just beware the high dysphagia, localized to the throat, may be associated with neck swelling, gurgling, aspiration events, a previous failed esophageal intubation. Think pharyngeal pouch. A barium study may be a better first-line test here than referring for an endoscopy. So, neurological, oropharyngeal problems, common in the elderly. Involve disorders of the tongue and the pharynx. It may be of sudden onset with a vascular cause. It may be chronic. It may be neurological symptoms that will support the diagnosis and time related. Fluids characteristically are harder to swallow than solids. That's a classical of a dysmotility or a coordination issue rather than a mechanical problem. And often the problem starts with initiation of swallowing rather than the food is swallowed and then a subjective dysphagia. Often food's left in the mouth. That's uncommon with esophageal problems. Cough on swallowing and postnasal regurgitation imply failure of the protective mechanisms and aspiration risk. These guys need a salt assessment, a neurological workup, maybe an ENT referral, rather than an endoscopy. And perhaps there's a list there of neurological causes. Stroke is a very common one, obviously. But there's a lot of other things, and dementia is an issue there as well. So investigation dysphagia. We've talked a bit about history. And those are the studies, endoscopy at the top, that's the subject of this talk, backed up by these other modalities. So here's a sort of algorithm for investigating dysphagia. If you've got oropharyngeal dysphagia, as we've mentioned, you're best going down the route of salt referral, video fluoroscopy, and ENT neurology. If you've got esophageal dysphagia, is this malignant dysphagia? Well, most new dysphagia, weight loss, progressive, rapid onset, is pretty worrying. You want to be getting on with an endoscopy on a 2-week wait pathway. And you'll then pick up, I don't know if the pointer is actually, you'll pick up sort of diagnostic cancer, a stricture, whatever. If your endoscopy is normal, then if you've got dysphagia for solids and not liquids, then a barium study may be useful. You can miss structural pathology on an endoscopy, particularly webs, rings, strictures cannot be appreciated sometimes. But if you've got dysphagia for liquids and solids, then the best test then is referral to secondary care for high-resolution manometry to pick up a dysmotility disorder. And if that's normal, then we're into the realms of a functional disorder. If you've got sort of reflux symptoms, and is it dysphagia, is it malignant dysphagia, is it just a bit of intermittent dysphagia every so often, been going on for years, and there's a lot of heartburn, then it's quite reasonable actually to have a trial of a PPI, and if all the symptoms go away, then you may be able to get away without an endoscopy. But if the symptoms persist, dysphagia is more prevalent, or you've got a pre-malignant existing condition, a known Barrett's patients, then by all means get on and get the endoscopy done. And so on to sort of the esophagus, and this is where the endoscopy is the king of investigation. There's a number of different conditions I'll quickly run through. So reflux disease is perhaps the commonest problem that you see in primary care, and a very common referral. Affects a large proportion of the Western population. It is a disease of Western excess, but most is non-erosive. In other words, you get symptoms, but you don't get damage to the gullet. About 30% get esophagitis, and that can proceed to a peptic stricture, which can cause dysphagia. Barrett's in about 5 to 10%, and of course the one thing we're always worried about is cancer. So non-erosive reflux disease, heartburn, postprandial and postural symptoms are common in the history. It's very uncommon to have significant dysphagia or severe adynophagia with this condition. History can be helpful. A trial of PPI in primary care is quite helpful, though not that specific or sensitive. H. pylori testing is usually advised by NICE because there is an overlap with dyspepsia, and some patients can't localize their heartburn very well, so testing H. pylori is relevant, although H. pylori is not in the etiology of heartburn. OGD is useful for resistant or refractory to PPI symptoms where you're a bit unclear about the diagnosis. It is not a good test for recurrent symptoms. If you're responsive to a PPI, you don't need an endoscopy, you just need to address your lifestyle and carry on with the PPI. We can talk about screening in questions. Remember, an endoscopy is normal in the majority of cases, or there's a small hiatus hernia. pH studies are actually the gold standard for investigating because you can marry up reflux with symptoms, because a normal endoscopy actually doesn't give you a diagnosis. I'd say there's little role for barium studies. So esophagitis, interesting people, we grade esophagitis from various grades from A, where there's a tiny bit of inflammation, to D, where there's confluent circumferential inflammation. It doesn't correlate well with symptoms. You can have just as bad heartburn with a normal endoscopy as you have with the grade D esophagitis on the bottom right. Grades 3 and 4 esophagitis found, we do tend to advise that they have repeat endoscopy after high-dose PPI to check healing and make sure that there isn't an underlying Barrett's we can't see, which can occur up to 25% of people with grade D esophagitis. If you get an endoscopy report saying grade A esophagitis, that is not evidence for reflux disease, in fact, because it is a very common normal finding. Grade B is a bit controversial. It might signify reflux. It might still be in the realms of normality. But grade C and D, pretty obvious ongoing disease. So peptic strictures, these slides will probably look better in your handouts or your slides on screen than they do on the big screen. There's an inflammatory stricture at the top with horrible inflammation, and then after 3 months of PPI, you've got a nice healed gullet there, but there's still a bit of a stricture there, and endoscopy may be useful then as a dilatation procedure therapeutics. These patients, if you've got a stricture, often need high-dose maintenance PPI, not standard dosing. So here's Barrett's. Barrett's is important because it has a pre-malignant potential, but that pre-malignant potential is quite small for most Barrett's, 0.3% per year, and it doesn't sort of accumulate 0.3, 0.6, 0.9. It probably reduces with time if people have a low sort of short segment Barrett's. But if you develop dysplasia, you've got a much higher risk of cancer, 1% per annum for low grade, 10% per year for high grade. And sort of points for primary care is someone develops dysphagia in between surveillance intervals, which can be anywhere from 6 months to 5 years, depending on the length of Barrett's and presence of dysplasia, then they should be referred urgently on 2-week wait pathway. Because quite a few cancers we find do occur having had a normal sort of surveillance or endoscopy within 3 years. The other thing perhaps to say is there is no role for surveillance for high-grade dysplasia, high cancer risk. It should be treated or the patient's unfit for treatment left. And this is what we're all worried about, esophageal cancer. About 8,000 cases per year. Full-time GP, therefore, see one every 3 to 5 years. I'm seeing about one a week at the moment. There's quite a bit of post-COVID coming through. It's got an appalling 5-year survival rate. Endoscopy is the gold standard for diagnosis and allowing histology. Your NICE guidelines say when should you refer a patient with suspected esophageal cancer? Urgent direct access endoscopy within 2 weeks should be performed for people with dysphagia of any age, or people age 55 is sort of an arbitrary sort of cutoff with weight loss being a very, red flag symptom plus dyspeptic symptom. If you're a bit unsure, is this malignant dysphagia, is it not? There is a scoring system called the Edinburgh Dysphagia Score, which is quite useful. And it basically, if you score more than 3.5, you need a 2-week wait endoscopy. If you don't, you might still need the endoscopy, but it can be non-urgent because your cancer risk is low. And positive, or worrying signs are age, is perhaps the biggest one, presence of weight loss. If you've got dysphagia localized to the neck, that actually removes points because you're less likely to have esophageal cancer. If you've got reflux heartburn, you're less likely to have cancer. Interestingly, people with cancer often don't have heartburn because they've developed Barrett's, a resistant lining. Often they lose their heartburn, so there may be in a preceding 10, 20-year history of heartburn, but they haven't had heartburn recently. Then they get their dysphagia. And being female lowers your risk as well. So, and duration of symptoms, if it's long-term dysphagia, that removes points as well. So that might be a useful sort of scoring system for you to sort of take note of in terms of directing the triaging of your referral. Okay, so away from reflux and cancer, foreign bodies. Commonest foreign bodies, food bolus obstruction, sudden onset after eating. There's some chicken sitting in someone's gullet. Luckily, this talk isn't before lunch. There are often preceding history clues. You can try carbonated drinks to shift food, but if there's very poor evidence for drugs. But if the patient has absolute dysphagia, if they're drooling, they need to be admitted. There's a danger of aspiration, and ideally they should be admitted to gastro unless they've actually got airway compromise, in which case they should be under surgeons and ENT. And they need an OGD often to remove and diagnose the underlying disorder. And does anyone know what the commonest disorder causing food bolus obstruction is in the country at the moment? It may be a condition you've not heard of, eosinophilic esophagitis. I'm not going to talk much on it because the king of EOE is speaking at 2 o'clock this afternoon. But this is not an uncommon problem. It commonly presents with food bolus obstruction. The endoscopy may actually look normal. So if someone's had a food bolus obstruction, it's cleared in ED and they've been sent home without an endoscopy, please refer these people back to us for an endoscopy to make the diagnosis. If they've had an endoscopy but no biopsies taken, please refer the patient back to us to have an endoscopy with esophageal biopsies to pick up the diagnosis. The pictures on here show sort of end-stage damage to the gullet with fibrous rings and strictures. We don't want the patients to progress to that. So sometimes the esophagus can look relatively normal, but we find all the eosinophils on biopsy. So non-food foreign bodies, usually these are no esophageal pathology. The pathology is usually mental here. You've either children, prisoners, and people with mental health issues. I don't want to classify them all as the same group, but they do tend to swallow things they shouldn't. If they've got dysphagia, they should be admitted. There are certain things that should never be left in the gullet, even for an hour or two. Button batteries. There's a picture at the top there, the button battery that's been in a child for 2 hours. It's already eroded through and caused mediastinitis and a perforation. These things need to come out straight away. There are other things which are high risk, sharps, large objects, which are unlikely to pass. Magnets, it's not uncommon for us to get magnets now. The little magnets picked off the iPad's common thing. If you swallow 2 of those and they get through into your gut, different parts of the gut, they can come together and cause a pressure necrosis through the bowel wall. So early endoscopy for those, they'd rarely cause dysphagia, of course. Esophageal dysmotility, well, we said dysmotility is usually diagnosed with high resolution manometry. Endoscopy is usually normal, but if you've got gross dysmotility, you may see something like this corkscrew esophagus or this achalasia in the bottom picture where there's resting fluid. The GOG seems a bit tight, but passable. There's no stricture endoscopy there, but barium shows this standing column of barium there, and high resolution manometry will give the diagnosis. If you've got someone with dysmotility who's having aspiration or nutritional compromise, they do need referral and workup. Here's a sort of acute medicine emergency, which often under-recognised. Gastric volvulus, known large hiatus hernia, suddenly gets dysphagia and pain and vomiting. The stomach's twisted. It's a medical emergency because that twist can induce ischemia and they can aspirate. They need to be admitted emergency-wise. They do not need an endoscopy, they need an NG tube. Decompresses the stomach, untwists, patient gets better. Perforation presents with absolute painful dysphagia post-vomiting or instrumentation. Again, a common cause actually is EOE. So if you've got someone who's come to see you and they've been vomiting and then suddenly they've developed really painful dysphagia, they need admission. They've got a perforation and 2 proven otherwise. The role of endoscopy here is if we catch them early, we can sometimes close the perforation or put a covered stent in. But the diagnosis really is CT and thinking about it, and then thinking about EOE if there's no obvious underlying cause. And then just think some dysphagia's got nothing to do with the gullet. Intrinsically, it can be extrinsic. So you may have a normal OGD, but you've got a malignant dysphagia type history, progressive dysphagia, weight loss. Are there extraesophageal symptoms of chronic cough, hemoptysis, smoker? Have they got a previous history of breast cancer? These guys need a CT scan. There may well be extrinsic compression from lymphadenopathy or a primary pressing on the gullet. Here's a sort of picture you probably can't appreciate, but there's a big bulge in the gullet causing dysphagia. That's an aortic aneurysm, not something to biopsy or EUS. So take-home messages. There are different types of dysphagia, different presentations, and history can guide those initial investigations. And endoscopy is not required for everyone with dysphagia, particularly oropharyngeal. Be aware of adenosphagia and globus. It's not cancer. And I've given you some clinical tips for some different conditions to think about. Don't forget cancer red signs and flags, and be aware of a condition of EOE, which you'll hear more about later. Thank you.